Welcome to Automatic External Defibrillator, the AED. This is Simsbury Volunteer Ambulance AED Refresher Training. We're going to talk today about the LifePak 500 LP 500, which is the ambulance. But before we get into the defibrillator itself, let's just kind of refresh regarding the cardiac chain of survival and the situations in which we would be pulling the defibrillator out. So the cardiac chain of survival is 5 different things that go together, and it's a link or a chain. And if any part of the chain is broken, then the link itself will not operate as it should, and therefore the outcome for the patient involved may be poor. So let's just kind of, as a refresher, just remind you what that is. The first step in the chain is early recognition that there's an emergency and calling 911. So let's think about it. Sometimes people don't recognize that an emergency is occurring and 911 isn't initiated. So recognition is a big deal because we can't start the chain without recognizing the emergency. CPR or CCR started early, immediately upon recognizing the patient is pulseless or apneic or agonal breathing, initiating compressions. And remember that CPR changed the way we initiate CPR. It went from ABCs to CAB, so we are going to start with compressions first and then evaluate the airway and breathing. Early defibrillation is the next step, so that's getting the AED, knowing where it is, how to apply it, how to use it. Usually when the AED does not work, it's usually human error. It's not a manufacturer's issue. So we'll talk about using the AED correctly. Also is advanced emergency care. Obviously, you've recognized the emergency, 911's been called, CPR is going on, defibrillation has happened, an ambulance is en route, that's number 4, and medical personnel are there to take over care and transport the patient to the hospital. And the final chain, or the piece of the chain, is post-cardiac care, and that's everything that happens after the event. The patient now has a pulse, they're in the cath lab, they're up on the step-down unit, they've been discharged home. All of those things go into the post-cardiac care in the cardiac chain of survival. It looks like this. You guys have seen this. The 5 rings, nope, not the Olympic rings, but the 5 rings of the cardiac chain of survival. And smack dab in the middle is early defibrillation, which is what we'll be talking about today. So when we're talking about a cardiac event or an acute coronary syndrome, what are the signs and symptoms of a myocardial infarction? Well, we'll go into what the typical signs and symptoms are and what some atypical findings are. We'll talk about what our pre-hospital care is as an EMT and at the EMTB level for anyone that we suspect is having an acute coronary syndrome or MI. We'll talk about what to do in a cardiac arrest. Obviously, we're going to talk a little bit about CPR versus CCR. CCR has been around in our protocols for a year now, so you should all be very familiar with CCR, but we'll touch on that a little bit. And then we'll talk about our AED, specifically the LifePak 500. Yep, there's going to be a test. See my little unhappy face, but don't worry. It's only 20 questions, and they'll be fairly straightforward questions, no tricks involved. So signs and symptoms of myocardial infarction. Usually it's some type of chest discomfort. It could be pain, it could be pressure, it could be just an ache that just doesn't feel right. But it is the most common symptom. This pressure, pain, or ache, whatever the discomfort is that the patient's describing to you, it's not intermittent. It's persistent. It has been lasting at least for 3 to 5 minutes. A lot of patients wait much longer to call us. Sometimes patients may report that it started a day ago and it was relieved and then it came back, and now it's not relieved anymore with what they did yesterday. For instance, you'll have somebody who may have been very active the day before, cutting the lawn, doing yard work, gardening, whatever, and they developed some chest discomfort. They stopped what they were doing, they came in, they relaxed, rested, and it went away. But now today, it's not going away. Maybe it's not going away with rest. Maybe it's worse with activity and just will not be relieved by any means possible. We want to find out exactly where this discomfort, pain, or pressure is located. Is it substernal? Is it in the arms, and it can be the left arm, can be the right arm. It can occur along the abdomen, usually the upper abdomen, epigastric area. Some people may complain of like a burning sensation as if they're having heartburn. It can be between the scapulas. They can feel it in the back. Sometimes the chest discomfort does sit in the center of the chest, but it radiates somewhere. Maybe it radiates to the shoulder, to the back, to the arm, to the neck, or to the jaw. So you also want to determine, aside from feeling the discomfort in your chest, where else are you feeling it? Does it go anywhere? Does it radiate? Are you feeling it in any other parts of your body? Do you have any other symptoms associated with discomfort, like shortness of breath or trouble breathing? That would be an associated symptom. Sometimes the patients look like they're breathing fine, but they're telling you, I just don't feel like I'm breathing easy. Now remember, when we assess breathing, breathing should be effortless and it should be quiet. So if it's not effortless and it's not quiet, they're having trouble breathing. But again, they may look like they're breathing okay, but they may say to you, I feel like I'm having trouble breathing. You also want to look at what their O2 sats are. Sometimes they don't realize they're having difficulty breathing, and you look at their O2 sats and they're tanking 90%. Or maybe they look like they're having a lot of trouble breathing, but their O2 sats are 98%. So obviously you want to take in and use the tools that you have to assess and evaluate and trend what's going on with the patient. So shortness of breath and trouble breathing may or may not be present. That's an associated symptom. They may or may not have oxygen levels. Again, that's just something to track and evaluate. They may complain of nausea with or without vomiting. They may not have any nausea at all, but that's another associated symptom. Lightheadedness, dizziness, weakness, loss of consciousness, or syncope, that may be the only symptom. Maybe they have no pain, pressure, or anything else, but they're complaining of feeling lightheaded and they've passed out. That's something also that we need to look into and determine whether or not there's a cardiac event going on or a neurologic event or a metabolic event. Their color may look completely normal, or they could be pale, ashen, grayish, or bluish in skin color, so it looks like they're not perfusing very well. Diaphoresis is a symptom that may or may not be present. Sometimes they only have sweating around the forehead and temples. Sometimes their whole body is drenched in sweat, and sometimes they're just pink, warm, and dry, but they still could be having a cardiac event. So you have to look at all the symptoms they're having. What is their chief complaint, and what other symptoms are occurring in addition to that? So look at the whole picture. Unfortunately, with cardiac events, a lot of patients deny or wait to call 911 because they really don't believe that they're having a heart attack, especially if you think about the guy that was out cutting the lawn the day before, and when he came in and sat and rested, the symptoms went away. Well, here it is the next day. He's sitting doing nothing, and the symptoms are back. He can't rest because he's already sitting, and he's going to wait a while because he's going to say, well, it went away yesterday. Maybe it'll go away today. And when it continues to persist, stays the same or gets worse, or he starts feeling poorer, doesn't feel as well, that's when the phone call is made and the 911 call is made and the ambulance is summoned. But denial of symptoms is always something to consider when you're evaluating your patients. So you get called out for someone not feeling well, and oh my God, you realize your patient is having some of these MI type symptoms. What are you going to do? Well, you have your BSI on, you've already determined the scene is safe, you're walking in the door and you're going to eyeball your patient. And you're going to decide at that point, is my patient alert, not alert, breathing, not breathing, and do they look awful or do they look stable? So stable versus unstable. If you're thinking heart attack, MI, or some type of cardiac event, then you need to request ALS. So try and do that early. So make a decision early. If your patient is not sitting, is up, moving around, trying to collect things, have them stop, sit down, and put them in a position of comfort. We don't want to increase their oxygen demands or their cardiac, their heart rate, their cardiac demand. So let's get them in a place where they can sit and be evaluated. We also want to assess, obviously their level of consciousness. We want to get their chief complaint. We want to determine if there's any immediate life threats that need to be managed right away. And then we're going to assess airway, breathing, and circulation. Is their airway patent? Are they breathing okay? How's their pulse? Do I have a radial pulse? If I do, how's my blood pressure? If I don't have a radial pulse and they're not breathing, do I need to be starting compressions? We're going to get a baseline set of vitals if they're not in cardiac arrest, and we're going to get a sample history. Whether they're in cardiac arrest or not, you want to get a sample history. You want to find out what were their signs and symptoms, what are their allergies, what are their meds, what's their pertinent past medical history, have they had 12 stents, a couple of bypasses, hypertension, diabetic, and they're sedentary and obese. What was their last oral intake, and what were the events leading up to this event? These are going to be important pieces of information that we need to pass on to the hospital. If they're awake and talking to you, loosen up any clothing that may appear tight or uncomfortable. We want to make them extremely comfortable. We want to decrease their anxiety. We want to reassure them that we're going to take good care of them. I keep a Johnny or a hospital gown in the back of the stretcher for this reason, because I know at some point they're going to get an EKG, so we're going to need to expose their chest. At some point we may have to put the AED pads on, so obviously we need to expose their chest. So rather than waiting until the life-threatening emergency happens, let's prepare for it. If it doesn't happen, great, we were ready. If it does happen, we have all of our tools around available, and we've done everything that we need to do, because the last thing we want to be doing is trying to take clothes off of somebody who's completely unresponsive. We want to continually reassess these patients and continue doing that so we can provide a good trending of what's been going on and provide a very well-organized report to whoever is taking over. Whether it's ALS or you're transporting to the hospital, you're going to give report to the docs in the ER. Obviously, you want to document any changes in your patient's appearance, behavior. Hypoxia is a big deal with these patients, and one of the first symptoms of hypoxia in all patients is altered mental status, because remember, there's not enough oxygen getting to the brain, so therefore the brain begins to act in an unusual way. They become altered. One of the first signs and symptoms would be agitation. So we don't want our patients to be agitated. We don't want to increase their heart rate. We don't want to increase oxygen demand. We don't want to increase the workload of the heart. So obviously we want to treat the agitation. We want to make sure that we're giving them oxygen. We're providing them with comfort, reassurance, and limiting any activity that they may have. You want to be prepared to transport these patients without a paramedic on board if you have to. So in a situation where it is better for the paramedic to intercept with you than it is for the paramedic to meet you on scene, consider that as an alternative, because the goal is to get this patient to the hospital as soon as possible. If they are having a cardiac event, it seems cardiac, sounds cardiac, they look bad, the likelihood of them going into a lethal arrhythmia is significant. So therefore we don't want to be on scene and wasting time. So if we can talk with the paramedic or whoever is coming to meet us, maybe intercepting would be the better choice. So always keep that in mind as an alternative. So some things that I kind of alluded to when I talked about the sample is we do want to obtain a list of medications and allergies and find out if they took anything prior to your arrival. Maybe they already took aspirin, maybe they've taken nitro, maybe they're allergic to aspirin, maybe they have asthma. So maybe there's some medications that you would normally give them, but it's contraindicated in this particular situation because maybe they have a history of recent GI bleed. Maybe they're allergic to aspirin. Maybe they have asthma. Maybe you don't want to give it because they've already given it. But certainly we will also want to determine whether or not they have the ability to follow our instructions, chew the aspirin, and swallow it. We want to give them baby aspirin. We want them to chew it. Baby aspirin is 81 milligrams. We give 324 milligrams. We don't want to give enteric-coated aspirin because that defeats the purpose. You can give an adult aspirin, provided it doesn't have a coating on it, and have them chew the adult aspirin. That's going to be very bitter tasting, but certainly if that's all you have available, that's what you can give. We carry aspirin on the ambulance in the medic bag, so any aspirin you give would be probably from the patient's own stock of aspirin. I'm not going to get into the rights of medication administration. That's a whole nother presentation, but make sure that you are following the rights of medication administration, right patient, right route, right time. There's no contraindications at all. You can have the right indication and it hasn't expired, all of those things. There's also another medication that you can consider, and that's giving nitroglycerin, provided they have nitroglycerin prescribed for themselves. You're not giving nitro that's prescribed for somebody else. Obviously, if they have their own prescription, you want to find out, did you take your nitro? If so, when? You want to determine whether or not the nitro is expired, because sometimes patients don't get any relief because they're taking nitro that's expired. Nitro that's been exposed to sun degrades, so if they have their nitro in a baggie or some other type of container other than the original container, then nitro may not be any good. You also want to determine, prior to giving any nitro, have they been taking any erectile dysfunction drugs in the last 2 to 3 days? You want to make sure their blood pressure is okay, because you can't give nitro if their blood pressure is 100 systolically or less. So obviously you must obtain a set of vital signs. And then if you find that there's no contraindication, their blood pressure is good, it's their nitro, and you go ahead and give them their nitro, you want to reassess. You want to take another look at their blood pressure, make sure they're feeling okay, and determine whether or not it had any effect on the discomfort that they're experiencing. I talked about hypoxia, so we are going to give these patients oxygen if they're feeling as though they're not getting enough air, if they're acting agitated or altered, if their O2 sat is less than 94%, we're going to go ahead and give these patients oxygen. If they're satting above 94% and they have no respiratory complaints at all, there's really no reason to give them oxygen. But if they're acting altered, if they're stating that they're short of breath, if you know they're short of breath, their respiratory rate is up and they look like they're having trouble breathing, then go ahead and administer oxygen. Start with 2 liters, then give 4, and then increase it to a non-rebreather. Because again, your goal is to get them to a place where they're feeling like they're getting enough oxygen and respiratory rate is within normal limits and the oxygen saturation level is above 94%. These patients are at risk of developing lethal arrhythmia, so you want to place the AED pads on these patients. So once the AED pads are on, and you want to tell them what you're doing. I'm going to place some special pads on the patient. It's required by protocol that anybody having this type of chest discomfort, that we place these pads on the patient, and we also need to put you in a gown. But also in the back of your mind, be ready for them to go into cardiac arrest. If you expect it and anticipate it and plan for it, you're going to be ready if it happens. But if you don't expect it and don't anticipate it, you're going to be completely surprised and caught off guard, and you're going to be chasing your tail. So make sure that when you load these patients up, that you know where your OPAs are, you have enough oxygen on board, you know where your BVM is, you've got enough hands to start CPR, and you got enough hands for somebody to operate the AED. So just briefly about cardiac arrest. They've done a number of studies and they found that not always will people recognize that someone's in cardiac arrest. And you probably say to yourself, well, how could that be? Well, it does happen. So someone that is unconscious and having agonal respirations, a lot of times people will assume they're breathing, but they're breathing funny. So they won't bother to check a pulse and they'll find that they would be pulseless. Agonal breathing is just a dying respiratory pattern. At some point it will stop. Agonal breaths are noisy, they're erratic, sometimes they are deep, and what happens is you have these long, weird pauses in between these strange respirations, these noisy respirations, which goes back to one of my earlier slides. Adequate breathing is effortless and quiet. So if you have somebody that is unconscious, unresponsive, and they have a funny breathing pattern, check a pulse. They may not have one. And again, our treatment would be either CPR or CCR and early ventilation. There is a whole video on CCR, so if you haven't looked at that, look at that. It goes into when we do and do not do, when we use CCR versus CPR. So basically, in a nutshell, CPR, American Heart Association CPR, which we all carry a card for, is cardiopulmonary resuscitation. It's basically a combination of chest compressions and artificial ventilations. CCR is chest compressions with passive administration of oxygen via non-rebreather mask. These patients have to have a patent airway, so an OPA is going to be in place. That's the difference between the two. Both of them will circulate blood to the vital organs, including the brain, and both of them will increase the patient's chance of survival if done correctly and initiated early. The goal of both is obviously to keep the heart alive, keep all the vital organs alive, keep the brain alive. And if you can keep the heart alive, when you administer a defibrillation shock with your AED, the heart should stop all of the erratic rhythm, chaotic rhythm that's there, and hopefully restart itself via the SA node into a normal electrical pattern. So obviously, a heart muscle is going to respond positively to defibrillation if it's well perfused. In other words, it's getting blood and oxygen. The only way it's going to get blood and oxygen is if we're doing very good compressions. That's why we don't want to interrupt our compressions, or at least if we have to interrupt them, it should be less than 10 seconds to do whatever it is, whether we're moving patients, checking a pulse, whatever it is, loading them in the stretcher, loading them into the ambulance, bringing them from one location of the house to another, whatever the case may be. 10 seconds is all we want to stop compressions for. Anything more than that, the likelihood of the patient having a good outcome is going to decrease. Obviously, the sooner we recognize cardiac arrest, the sooner we're going to begin compressions, and therefore the likelihood of having a good outcome is increased. So this is something that you've probably heard before. The key to a successful cardiac resuscitation effort is good BLS care or great BLS care. Everything that I've talked about here initially that goes on is all BLS care, and if it's done really, really well, the patient should respond well to defibrillation, IV fluids. They should respond well to medications if we even need to administer them. So it's real important to recognize the cardiac event and intervene early. If more than 4 minutes has elapsed since the time the patient has become unresponsive and their heart has stopped, and then 4 minutes or more goes by before any type of intervention is started, the chances of a good outcome is slim to none. So obviously that's why this cardiac chain of survival is so important. Recognizing the patients in cardiac arrest, calling 911, starting compressions, early defibrillation. And just a reminder, because I've seen this happen where, we always want to start our compressions wherever the patient has collapsed. But if they're in bed or on a couch, we need to take the few seconds that's necessary to get them to a hard surface, because that firm surface is a big deal when it comes to ensuring that we're getting adequate depth with our compressions. The softer the surface, the less likely we are to really be compressing the chest or heart. So obviously, your surroundings and decide, is this the best place for us to be doing compressions? Briefly again with CCR, it's compressions, chest compressions at a rate of anywhere from 100 to 120, no more than 120, with passive administration of oxygen early on in the cardiac arrest. Okay, we're not doing this throughout the whole entire arrest. We're doing it early on during the first 4 to 8 minutes of the sudden cardiac event. We're going to do these for cardiac events only that occur suddenly. We're going to use this on adults. We're going to use it if there are no symptoms of respiratory distress prior to the collapse. So it's not a respiratory event that caused the collapse. And also that the cardiac event is not due to trauma, drowning, or hypothermia. So if I have somebody that has had a respiratory arrest or some type of trauma, drowning, or hypothermia, we're not doing CCR, we're doing CPR. So you notice in there I didn't mention kids. We're not doing CCR on kids because kids typically have cardiac events because of a respiratory event or an illness or a dehydration, which leads them to go into cardiac arrest. So obviously with kiddos, the act of giving oxygen is going to be a high priority. with their cardiac arrest. So just some facts that we need to think about. Cardiac arrests occur mostly in the pre-hospital setting. They're out of hospital. So therefore, that's why we want the bystanders, the 911 service, the first responders, and the ambulance services to be on the same page and understand how important it is to begin CPR and defibrillation early. We need to recognize and begin CPR or CCR because that will improve the patient's chance of survival. That's been studied, and we found that to be true. In a cardiac arrest, frequently, very often, the initial rhythm is a very chaotic electrical pattern that we call ventricular fibrillation. And in that situation, the heart is quivering. It's not filling, it's not pumping, it's not doing what it needs to do. So therefore, if it doesn't fill, it doesn't pump. There's no blood going to the vital organs. There's no blood going to the brain. There's no blood going to the heart because it's not adequately pumping. So this chaotic rhythm is called ventricular fibrillation. You may also hear it referred to as VF or VF. So the defibrillation is needed to stop this chaotic electrical pattern. And that's all we're doing is we're shocking the heart out of this rhythm. We're not shocking it into a new rhythm. We're actually shocking it into what we call asystole or flatlining. The reason why we do that is because the SA node, which is located in the right atrium, is the normal pacemaker side of the heart, and we're hoping if we stop the chaotic electrical pattern that the SA node will then say, oh, now I can do what I need to do. Now it's my time to send the electrical impulse down the normal pathways so that the muscle of the heart can respond. And if we can stop that rhythm pretty quickly, the chance of the patient surviving is increased. This particular rhythm strip is showing the two shockable rhythms that an AED recognizes. This is called VTAC. You can see the heart rate is about 163 beats a minute. With this rhythm, VTAC, the patient can be awake and have a pulse. They could be unresponsive without a pulse. Then the second rhythm that we see more than likely in our cardiac arrest is VFib. And notice that you just got a wavering kind of baseline. There's no true pattern to this. This patient having the rhythm on the bottom is going to be unresponsive, pulseless. And this is the patient we're going to start CPR on. And those are the two rhythms that the AED will recognize. So let's look closely at cardiac arrest. Who has cardiac arrest? And in what kind of people does this happen? It happens in people with underlying disease, coronary artery disease, hypertension, diabetes, just some type of underlying disease that interferes with the circulation or the circulatory system of the heart. You can also have patients that have injury to the heart. Maybe the injury is after an MI and the heart hasn't healed very well, and there's some areas of the heart that are dead and can't hold an electrical impulse, and so therefore you have some weird, quirky electrical patterns going on that can disrupt the normal pattern of the heart. Our goal here is to stop whatever non-perfusing rhythm is occurring so that the normal pacemaker of the heart can kick in and restore the normal electrical pattern. And if we can restore that electrical pattern, the heart will begin to contract or pump, and we should get a pulse back and possibly even a decent blood pressure. So just reiterating, the two rhythms that are shockable, VTAC and VFib. And VFib is the most common rhythm that we would see in a cardiac arrest. Luckily, these two lethal rhythms are very treatable and they can be fixed, provided CPR is started early, the recognition that someone is in cardiac arrest, and getting the defibrillator out there quickly. Good BLS care. Now, we talked briefly just for a second about children regarding CCR, but just remember that cardiac arrest can also occur in children, and kids can go into these lethal arrhythmias. You just need to look at the history behind what led up to the arrest to decide, am I doing CCR? Am I doing CPR? Do I need to defibrillate the patient? and kids do respond to defibrillation as well. We just need to look at the types of pads we're using and make sure that we have the right pads on for the right size patient. So we'll also discuss that when we go a little bit further into using our AED. But cardiac arrests do occur in kids. They do go into VFib, so therefore they do need early initiation of CPR, and they do need defibrillation as well. So going back to how to use our AED, obviously we have the LifePak 500 model. It's a semi-automatic device, which means it does some things on its own, but it also prompts you to do other things. This is what it looks like. It comes in its own carrying case. You can see there's a red, there's an orange, and a green button. There's also a little handle for carrying, and on the handle there's a little digital display that states that either the defibrillator is okay or it needs some type of intervention to ensure that it's working correctly. It has a case where it opens up and you'll find the pads up on top. So here's our sequence. We've recognized that somebody's in cardiac arrest. We've started CPR. After we've started CPR, we've asked somebody to go get a defibrillator because we know the most common rhythm that these patients are in is VFib. So we know we need to defibrillate these patients. So we're going to yell for somebody to get a defibrillator. They're going to bring the defibrillator to us. And then once we get the defibrillator, we're going to go ahead and apply the pads. We're going to go ahead and follow the voice prompts. And hopefully the patient's normal pacemaker will then kick in after we've defibrillated the patient. That's good BLS care. That's the sequence that we're going to follow. That's the outcome we're looking for. So great job. You knew exactly what to do. You recognized the cardiac arrest. You planned for what needed to be done, and you initiated the appropriate steps. So we'll take it from a 911 call. Stand by for tones. Stand by for a page. Car 10, car 4. You're going to whatever location for the unresponsive person. On your arrival, you determine that the patient is not breathing. Your general impression is, boy, they don't look to be breathing. This doesn't look good. So I'm going to initiate ALS and make sure that car 4 is on their way and coming. If they are called to the call with you, great. And if they aren't, you've got to get them going quickly. If the patient is breathing, you have to determine, is the breathing adequate? Is it a good rate, good depth, good quality, or is it not? And if it's not, you're going to have to intervene. You're going to assess for a pulse, no more than 5 to 10 seconds. If there's no pulse, you're going to start CPR or CCR, depending on the history, and then you're going to get the AED. So this is our LifePak 500. You brought the AED in with you. Someone is applying the pads while compressions is going on, and you're going to go ahead and use the green button. You're going to turn your AED on. Here are what our pads look like. They are quick combo pads. These are the adult pads, and you'll notice that there is a adult male standing pictured on the center of the outer wrapping of the AED pads, and you'll see a circle next to him which shows a baby. That means we can't use it on a baby. The pad should never be left open with the attenuator sticking out. And the reason is these pads are sensitive to light, they're sensitive to heat and cold, and they have an expiration date. And once you open them up, there's a gel on these pads, and you could potentially screw with the expiration date if you open them up and the gel dries out and you go to use them and you think they're okay and they're not. So you want to keep the packet completely closed until you're ready to use it. Once you've opened the packet, you'll notice that you have two pads. They're called quick combo pads, and it identifies exactly where each pad needs to go, and you can see the pads are attached to this nice little electrode. Here's the standard placement in an adult, just below the clavicle but above the nipple. Never place the pads over the nipple. You want it up above the nipple but below the clavicle. That's the anterior portion. It's going to be on the right side of the chest. And then you're also going to place the second pad just under the left nipple, almost on the axillary line. That would be the lateral pad placement. And you can see it pictured here. If you don't remember this, no big deal. It's also pictured on the pads themselves. You do have an alternate pad placement, so let's say you see something on the patient, and you're like, oh, I don't know if I should put the pad over the patient here. Certainly you can put your anterior pad underneath the nipple on the left side of the chest and then place the other one in a posterior presentation just below the scapula. You don't want it over the vertebrae or on the scapula. You want it below the scapula and just off to the side of the vertebrae. And that would be your AP placement as an alternative pad. The way that you've opened up the package, you've pulled the pads out, and the way you want to remove the backing is from where the electrode is. There should be a little tab, and you can peel the pad paper back. Okay, you don't want to peel from any other direction because you're going to have trouble finding where the little lip is. So you want to start where the electrode meets the pad, and you'll notice that there's a piece of the backing that's very easy to lift, and then just peel it straight back. And then you're going to stick it to the patient. Now, when you stick it to the patient, sometimes there's a little bit of a challenge. Maybe the patient has a lot of adipose. Maybe the patient has extremely large breasts. Maybe the patient's extremely thin. But the goal is to make sure those pads are in contact with the skin. So if you have someone that has some rolls or layers of flab, you need to flatten that out so that there aren't any lumps or bumps or rolls before you place the pad there. Because if you have gaps and the pad does not have complete contact with the skin, you are not going to be delivering the amount of energy necessary to stop whatever the lethal rhythm is that's going on that caused the patient to go into cardiac arrest. The pads are transmitting energy between one pad to the other. We have pads that move in one direction, or sometimes we have pads where the energy goes in one direction and comes back into the opposite direction. But that's a little bit more extensive, and I'm not really going to go into that right now regarding the monophasic and biphasic pads. But just know that the pads are operating where you have the heart in between the two pads, and that's how you're going to get the energy to the heart to get the heart to stop this chaotic, funky rhythm that caused the patient to go into cardiac arrest. If you have a very thin patient, it's also very hard to get the pads to stick in between each of the ribs. So with a very thin patient, you also need to make sure that you get that pad on there firmly and that there aren't any gaps, and the pad is not kind of riding over the ribs and leaving space in between with the depressions of the intercostal space. So really attach that pad correctly to the patient and firmly to the patient. Again, if you don't, you're not delivering adequate energy. And I said to you early on that a lot of times the defibrillator doesn't work correctly because of human error. So starting with and putting the pads on correctly is a big deal. Here are quick combo pads that are PD combo pads, and PD pads have a pediatric attenuator on them. Now, you'll notice that on the diagram or the picture on the left side of the screen, you'll see that you've got a baby on the center, depiction of a baby. So we know the pad can be used on a baby. Then you have an adult male, and you have the circle with the line through, which means we cannot use that pad, these pads on an adult patient. And then next to it, it lists the type of life pack that the pediatric pads cannot be used on. This particular set of combo pads are the combo pads that we carry at Simsbury Volunteer Ambulance on our Life Pack 15. We cannot use these pediatric pads on the Life Pack 500. If you look at that circle, you'll see in there the circle with the X through it, it says not to be used with a Life Pack 500. So we want to make sure that when we're looking at our Life Pack that we don't have the Life Pack 500 or our AED, that we don't have the pediatric pads for the Life Pack 15 sitting in the netted pocket of our AED. So do check that. Make sure the expiration date is okay, and make sure you're not carrying the wrong pads. The reason why the pads are a little bit different for pediatric patients is because when we put them on the Life Pack 15, which is the cardiac monitor that paramedic carries, we can dial in the number of joules we want, whereas the AED only gives a certain amount of joules. And with the pediatric pads that are made for the Life Pack 500, they have a pediatric attenuator on them. And again, just make sure, because I know that there's been a few times at Simsbury Volunteer Ambulance where I've opened up the Life Pack 500 and found the quick combo pads for a pediatric patient that are specific to our Life Pack 15, and they've been sitting in the AED pocket, and you don't want the wrong AED pads there. You cannot cut adult pads to make them the right size for pediatric patients. You can't alter the pads in any way, shape, or form. So don't ever cut the pads. The big thing about applying pads is you want to make sure that at least is a 1-inch gap between each pad. So you don't want the pads touching each other or overlapping each other, and you want to make sure there's a gap, at least between the pads. Here's an alternate placement for a pediatric patient. So you can have the sternum and it's AP placement, so you've got the sternum and also the back, equal places with the heart in between. This is for a patient 0 to 8 years old. Here's another example of how it would look on a pediatric patient. Again, this is an alternate placement for your pediatric pads. Again, don't cut the pads. The pads cannot touch each other, and the AED pediatric pads are device specific, so please look at the pediatric pads. You don't want to be carrying the wrong pads or put the wrong pads on the patient. Some things to think about once we've exposed the patient's chest, we've begun CPR, we've called for the AED. When we put the pads on the patient, we do not stop CPR to put our AED pads on the patient. The pads are placed in such a way that you don't have to interrupt CPR at all to place the pads. But you do want to take a quick look at the patient's chest and make sure that they don't have any medicine patches on. Make sure that you're not putting the pads on a pacemaker. Make sure you're not putting the pads over their nipples. If a patient has nipple rings or some type of jewelry, you can leave that in place. Just make sure you don't put the pads on them. But when it comes to like a pacemaker, and this picture is an example of where the pacemaker typically sits. It's just underneath the skin, and the device is thread through the subclavian vein down into the heart. This is a dual pacemaker, an AV pacemaker, but you'll see a little lump on the skin, usually in the pectoral region and usually on the left side. Sometimes you see them in other places, but usually on the left side. Do not put an AED pad over a pacemaker site. You will fry the device. And then if the patient survives the event, now they have to go through and have another procedure. So you want to avoid any pacemaker sites or bulges. Do not put pads over them. Sometimes you may not see the bulge and you just see the scar, and this is an example of a scar in the pectoral region on the left side of the chest. And if we were to see a view of maybe a profile view of this patient, we would probably see the little lump there. But certainly that's an indication that someone's had a pacemaker implanted. This is what it looks like. So here we have a nice gentleman showing us his upper pecs, and you can see the device there sitting just below the skin. Avoid placing any pads over a pacemaker. Here is a nitro patch. Remember nitro? Nitro as in boom. Do not defibrillate anybody with a patch on. You need to remove the patch. You have to have gloved hands. You're going to have to remove the patch and then wipe off any goop that's there. You want to do that before you defibrillate the patient or use your AED. You can also see nitro paste in this type of form where it's not a nice round patch, but it is what we call nitrobid ointment or paste, and it can look like this, and it's just attached to the skin and held onto the skin maybe with a piece of tape. Again, with gloved hands, you want to remove that from the patient's skin before you defibrillate them using your AED. You can see other kind of patches. You really don't have to know what the patch is, but I recommend if you see a patch on the patient, you may not see them all, but if you see a patch on the patient or it's near where the pads need to be, take the patches off. This is an example of a Duragesic or Lidoderm patch. Again, if you're unsure and it doesn't waste a lot of time, remove the patch. You also see things like nicotine patches, which are usually on the arms. It shouldn't make a difference. It shouldn't be a problem, but if you're unsure what it is, go ahead and remove it. A lot of patches have names on them, but the big patches that we're looking at are the ones on the chest, the nitro patches, and staying away from the implantable pacemakers or defibrillators, making sure we don't place the pads over those devices. So here we have a picture of our 500, LifePak 500, and you can see the green button, the on-off button, the analyze button, and the defibrillate button. And then I also highlighted where the electrode fits in. So obviously you've got the handle. This defibrillator reads OK, which means it's in fine working order, has plenty of energy, it doesn't need any type of maintenance, it is OK. Provided you see the OK sign, all is good. Up above, which you can barely see at the top of the picture on the left, you can see the AED pads are sitting in the little storage area. You would pull those out, open them up, and you would attach the AED electrode to the little adapter site, which is just off to the left of the handle. And I've made a quick picture of that too so that you can see it. It only fits one way, so it's easy to fit. When we're using the AED, just remember, in order for it to function correctly, we don't want it to shock a rhythm that's perfusing. So we want to make sure we stop all motion. That includes CPR, that includes moving the patient, that includes if you're driving down the road with the patient. So all motion needs to stop in order for the AED to analyze the rhythm. Once it begins analyzing the rhythm, we also don't want to touch the patient because, again, that can start some movement, and analyzing could be screwed up because of it. Again, talking about human error and just making mistakes. We push the analyze button. It will then analyze, and it will indicate through a voice prompt whether or not a shock is advised or no shock is advised. If no shock is advised, it'll tell you to continue CPR, and it times you. And you'll do CPR for another 2 minutes, and then the AED will then provide another prompt that it's time to, stop touching the patient, it's time to analyze the rhythm, and whether or not a shock needs to be delivered. So really, as long as you've set it up correctly and you've turned it on, it's going to tell you to attach the AED pads, attach the electrode, and then it's going to analyze the rhythm and tell you to stop touching the patient. And just follow those steps throughout the whole process. Now, the adult pads that are in the Life Pack 500, the AED, can attach to our Life Pack 15. So I've shown you a picture of the Life Pack 15 that we carry without the case around it. And you can see just off to the right, I've demonstrated that the electrode on the quick combo pad connects directly to our Life Pack. On the bottom right corner of the Life Pack, you can see a little cord or wire, and that wire has a little opening, which is pictured in the picture on the right side of the screen, and it's called the therapy cable connector. And basically, the top just flips open, and then we take the quick combo electrode. There's 2 little triangles on the top. The triangles meet each other to make like an hourglass. Snap it into place, and we're good to go. So what I'm trying to tell you is that you don't have to take your AED pads off if we're using the adult pads to connect to our Life Pack 15. Easy, it's seamless. So please carry the same one. So some things to consider when we're talking about AEDs and CPR and MIs is you don't want to stop your CPR, your compressions, CCR, to apply the pads. You want to make sure the victim's chest, the patient's chest, is dry. Remember, some of these patients may be extremely diaphoretic, but we want to get all of the moisture off of the patient because we don't want any arcing of the defibrillation shock. We want to make sure that dead skin is gone. Dead skin does not conduct electricity, so therefore we want to make sure that the dead skin is off the patient. We want to remove any hair or dirt from the patient's chest. Some patients recommend shaving the patient's chest if there's a lot of hair on it. You can take 1 set of pads, apply them, fix them to the chest, and then tear them off very quickly, and then use the second set because now you've got a clean area because you've just removed the hair from the patient's chest when you've ripped off the first set of pads. That's an easy way to do it. It's a quick way to do it. You can still be doing CPR while you're setting up the AED and applying the pads. Remember to connect the AED electrode to the AED itself. A lot of people, get very involved in what's going on, and sometimes it's the simple steps that are missed. Maybe they forget to turn on the AED and they don't know why it's not analyzing. So just make sure you've done it in sequence. The green button first, apply the pads, connect the electro. Orange button, analyze the rhythm. Red button, deliver the shock if it's advised. You want to make sure during the analyze process and during the delivery of the shock that no one is touching the patient. So that requires you to say, everybody clear the patient, and also to look to make sure everyone is in fact clear. And then you're going to repeat that when you're about to deliver the shock. Shocking on 3, everybody clear the patient. I'm clear, are you clear? Everybody's clear. Shocking, 1, 2, 3, and then you go ahead and press the red button and deliver that shock. Something to think about when we're talking about where a patient has a cardiac arrest. This happened a couple of times this winter where the AED was not applied to the patient that was in obvious cardiac arrest. It was because the patient was out in the snow. That is a misconception. The AED is rugged. It's made to be used in all different environments. If a patient is lying in snow, as long as their chest is not wet, you can go ahead and apply the AED and begin CPR and deliver a shock. You can absolutely do that in snow. Where you don't want to do it is if they are lying in a puddle of water, if their chest is wet, if they are on a metal surface. Those are the places where you don't want to defibrillate the patient, where the scene is not safe and you need to move the patient either out of the water, dry off the chest, or off the metal surface. But anywhere else, including snow, is A-OK. Something to think about it when we're ventilating a patient and we clear the patient, where you're saying everybody clear, nobody touch the patient, whoever is delivering oxygen to that patient with the BVM, please make sure the BVM is moved with them and away from the patient. We do not want oxygen running across the chest of a patient that we are about to defibrillate. If we, for some reason, haven't applied the pads correctly and there's arcing and we spark and we've got oxygen, we've got a terrible, terrible situation set up for burning the patient or having a huge injury because, obviously oxygen and sparks or fire are not a good thing. And we certainly don't want to cause more injury to our patients. So just make sure that when you're looking at how, where everybody is and who's ventilating the patient, how are they doing it and are they removing the oxygen source once you ask everybody to stop touching the patient and clear the patient. Hopefully that doesn't just come find me and I can explain it a little bit better. All right, so no one's touching the patient. We're not going to use alcohol to clean the chest. We're not going to cut the AED pads to make them fit the patient. We're not going to overlap the pads. The pads are going to have at least 1 inch around each pad so that they're not touching. We're also going to avoid using the AED or at least analyzing a rhythm when we're in a moving vehicle because the analysis may not be accurate. We want to make sure we're not touching the patient. We want to make sure we're removing patches. If you don't know what they are, remove them, wipe them off, use gloves. And this includes, your nitroglycerin patches and your Duragesic type patches. Just remove them if you don't know what they are. The other interesting thing is they found that anybody that is using a cell phone or a radio within 6 feet, actively using it, talking on it within 6 feet of the AED, can interfere with the AED's ability to analyze the rhythm. So think about how we respond to these calls. Everybody has a radio on their body. Sometimes you have police actively talking to dispatchers during the resuscitation attempt. So look around during the analyze. You're clearing the patient. Nobody's touching the patient. The oxygen source is safely away from the patient. And then if anybody's on the radio, they need to stop talking if they're within 6 feet. Because again, the analysis of the rhythm may not be accurate. It may be interfered with of the waves from the cell phone or radio. So in summary, I want you to understand the chains of survival. That should be second nature. I want you to understand the importance of excellent BLS care in all cardiac events. I want you to recognize signs and symptoms of an MI and know that sometimes the symptoms are very straightforward. Sometimes the symptoms are very subtle. Diabetics, women sometimes present a little bit differently and their symptoms a little bit different. So keep an open mind and, evaluate and assess each patient to the best of your ability and call for ALS early. If you think this patient is having a cardiac event or they look bad, definitely do that sooner rather than later. You want to evaluate your AED every shift. You want to know how to use it. Make sure the pads are in there. They aren't expired. They aren't open. They're the right pads for the right device, and that the AED itself on the handle says that it's okay. Prior to placing the pads, you're going to make sure that you put them in the right spot. You're going to clear any dirt, hair, dead skin, anything that's going to prevent a good contact with the patient. You're going to go ahead and ensure that the chest area is clean. Put them in the right place and make sure that it has good contact with the skin, taking into consideration patients that are obese, patients that are extremely thin. They both provide challenges with it when it comes to ensuring that the pad itself has 100% skin contact. Remove the medication patches from the chest area. You do have alternate AED chest placements and back placements. So if you do wind up in a situation where you have a pacemaker in a different spot and it's going to interfere with your AED, certainly go to the alternate pad placement. Not a big deal, but don't stop CPR to place the pad. You want to know how to use your AED. You want to know never to use it when the vehicle is moving. You want to make sure that the scene is always safe when you decide to deliver that shock, and make sure your oxygen source is not flowing across the patient's chest or the pads or the device. Following the voice prompts. I mean, that's the best way to ensure that you're doing and using the AED correctly. And if the voice prompts aren't, if the voice prompts don't occur once you place the pads on, look, troubleshoot. Make sure you've turned on the machine. Make sure that you've attached the electrodes. If you're checking the AED every shift and it reads okay, it should work correctly. And again, think about human error and go back through your steps again and see what it is you've done right or wrong and what you need to do to correct the problem. So at this point, obviously you can't talk to me, you can't ask questions, but you certainly know where to find me. So let me know if there's anything confusing during this presentation. And the next thing will be the competency assessment, which will be your 20 questions. So good luck with that, and thanks again for tuning in.